It's time for the Delaware Valley's first radio doctor.
On call every Saturday afternoon at 5.
This is Your Radio Doctor with Dr. Marianne Ritchie.
Presented exclusively by Independence Blue Cross.
Your health determines your life, your longevity, and your happiness. Let your radio doctor lead the way with your medical education. Your Radio Doctor, Dr. Marianne Ritchie.
Good afternoon and welcome to Your Radio Doctor. I'm your host, Dr. Marianne Ritchie. Menopause, a very important topic that deserves a lot of attention because every woman experiences it. Menopause is not a disease and it's not a disorder. It's a normal part of aging. Decreasing levels of estrogen and other changes which can cause a variety of symptoms in different women. To help us better understand this natural stage of aging and discuss the possible therapies, we welcome today's guest, Dr. Monica Christmas. How appropriate since this is the week before Christmas. Dr. Christmas is an associate professor of obstetrics and gynecology at the Pritzker School of Medicine at the University of Chicago, where she's also a member of the section of minimally invasive gynecologic surgery, the director of the Menopause Program and Center for Women's Integrated Health. She's also an avid educator who focuses research on expanding advocacy and optimization of medical care for disadvantaged populations. In addition, Dr. Monica Christmas is the first Associate Medical Director of the Menopause Society, the definitive international organization that offers evidence-based resources and information for healthcare professionals, researchers, media, the public, aiming to improve women's health and healthcare during that menopause transition and beyond. Welcome, Monica.
I'm so excited to be here. Thanks for the invitation.
Well, thank you. Let's start with the definition of menopause because I think we have a clear definition just to help people understand.
Well, natural menopause is defined as not having a menstrual period for a full year because your ovaries are no longer functioning. They've stopped making our reproductive hormones, specifically estrogen and progesterone. Now, menopause can also happen to people for iatrogenic reasons, like they had their ovaries removed. Many people that have endometriosis or had to undergo a hysterectomy for abnormal uterine bleeding may also have their ovaries surgically removed that puts you immediately into menopause because your ovaries are no longer there. Additionally, chemotherapy as well as radiation therapy can put people into early menopause as well because the ovaries stop functioning.
So typical age in the natural plan of things between maybe 45 and 55?
Yeah, the median age, that sweet spot that seems to be the magic number is typically about 51 and a half, 52. But the range that about 95% of people fall into is between the ages of 45 and 55. So I guess a better way to say that is by 55, 95% of people will have met the definition of menopause, not having a cycle for a full year. And so it's a retrospective diagnosis because at the time that you're having, the last menstrual cycle, you don't necessarily know that. And Mother Nature has a very cruel sense of humor, so that oftentimes, especially in those few years leading up to that final menstrual cycle, that's one of the first signs that menstrual cycles become irregular. Now, some people are fortunate. They might just stop one day, but most of us have have some changes to the menstrual cycle where they may start to get shorter, get lighter, they start to space out. Other women may notice that their menstrual cycles get heavier. They may even get longer or closer together before they go away. So all of it is normal, but that doesn't mean that, especially if you're in that category where the cycles are heavier or longer, that one, we don't get that evaluated to make sure it's not something else going on. But even if it is just perimenopausal changes, there are things we can do to help minimize the angst or the anguish associated with those troubling symptoms.
So you used an interesting word there, perimenopausal. Perimenopause, I guess that's that transition phase between no longer reproducing babies, no longer able because your periods become irregular, and then the time you stop. Average 4 years for that transition to happen?
Well, I will make it clear too that you could, it might not be as easy, but one could get pregnant during that perimenopause phase. Another terminology commonly used is the menopause transition. Right? So it's that time frame where we may start to experience symptoms related to hormonal fluctuations. However, you're still getting a menstrual cycle, even if that cycle has changed, and still making those reproductive hormones. So even though ovulation might not be as succinct or regular like in your reproductive years, it's still happening. So anybody that doesn't desire pregnancy should be protecting themselves. There's a classification that we use a lot for research called the straw classification, and it's looking at those stages. And so that menopause transition could take 7 to 10 years. And so it is completely normal for someone maybe in their late 30s, early 40s, certainly mid 40s to start to experience symptoms. And you could still be having a menstrual cycle, but one of those first signs based on the straw classification is changes to the menstrual cycle. So in the early menopause transition or early perimenopause, one would notice maybe a 7-day difference in cycle lengths or frequency. And then when we're in that late menopause transition or perimenopause time frame, menstrual cycles have started to skip at least 60 days.
So how would a woman know if she's in the transition that on average in some women might be a shorter time frame, a few years versus 7 to 10 years? How would you distinguish that transition from somebody who has ovarian insufficiency or early menopause where their system shuts down? I'm sure you have to look for other causes like thyroid issues. Tell us about that, if you would.
Well, early menopause is menopause that occurs before the age of 45. And primary ovarian insufficiency, it once was called premature menopause, is menopause that happens earlier than the age of 40. And so certainly somebody that's coming in that's 25 not getting their menstrual cycle regularly, you want to evaluate it. We want to make sure that it's not some other endocrine abnormality, that it's not polycystic ovarian disease, correct? But somebody that comes in that's right around the average age of menopause, and are symptomatic, absolutely, if there are other concerning things, doing an evaluation like a thyroid workup, but checking hormonal concentrations or levels is not helpful. It doesn't dictate how severe symptoms are, right? There are going to be many. There's not one menopause syndrome that every single person gets. Some people are rather fortunate. They may get very few to no symptoms at all. And then there are other people that will get every symptom under the sun that can be extremely debilitating to their quality of life. And it doesn't always reflect what your hormone levels are. So for example, somebody may come in still getting menstrual cycles, debilitating hot flashes and night sweats, horrible mood swings that are impacting their professional and personal life, keeping them up at night, weight gain, all of the things. And you go to check their labs and they're normal. That does not mean that they're not in the menopause transition, especially if they're 47 or 45, right there at that expected age range. It just means that at that particular day and time, the ovaries responded to the signals that their brain was sending. I could check those same things a week from then, a month from then, and it could be very different. And so when we're managing patients, we're really managing their symptoms, their most bothersome symptoms, and not treating to a certain hormone level. That's why hormone levels aren't effective.
Makes sense. What a great explanation, because it's interesting to hear you say some women just do not get symptoms. But in probably 80% of patients I'm reading, only about 20 to 30% of those people who do get symptoms get medical attention for them. So I guess there are probably a lot more women out there that just say, "Oh, this will be over soon," or they busy themselves, or they just work around them. So let's talk about those symptoms. I guess hot flash is the one that people complain most about because it comes on when it wants to. And let's talk about that.
About 80% of people will experience some vasomotor symptoms. There's the other name for them, and that's inclusive of hot flashes and night sweats. They're night sweats when they happen at night, hot flashes when they're happening during the day. They start in that perimenopause transition, more pronounced usually in the late perimenopause phase when you started to skip menstrual cycles. And it's pretty it varies from person to person. Some people have mild symptoms that aren't every day. They're, maybe triggered by having alcoholic or beverage or glass of wine. Some people will say, I know after I have a cup of coffee, I usually have a hot flash. Stress, sometimes when people are under more stress may experience it. And then you'll have patients that are having one at least every hour and extremely debilitating. And, as a healthcare provider, I don't make a decision as to how bothersome these symptoms are to somebody. I let them tell me what's bothersome to them, and then we go from there. In the menopause transition, it sometimes can be a little bit more tricky to manage them. You get lots of people, I think, social media is great for a lot of things, and I love that it is bringing menopause to the forefront. People are talking about it. It allows you to get information and also to feel empowered to discuss some of the things you might be experiencing with a healthcare provider, whereas before some people would say they felt dismissed. But the downside is that there's a lot of mis and disinformation out there. So I'm getting more patients coming in now, I'm demanding hormone therapy. You can't keep it away from me. And you talk to them and it's like, but I'm still getting a period every month. It's regular. It hasn't started to change. Well, what do you want the hormone therapy for? Well, I think I'm starting to feel warm at night. It's disrupting my sleep, but I've gained 10 pounds. I'm having a lot of mood swings and we'll talk to them and say, yeah, you know what? It does sound like you're probably perimenopausal, but hormone therapy is just meant to get somebody back up to their physiologic level of hormones, right? If you're in that perimenopause time frame and you're still having regular menstrual cycles, giving hormone therapy may make your cycles more irregular, make your bleeding a little bit more erratic, but it may not help because your issues are really stemming from these hormonal fluctuations. And so in that time frame, often continuous birth control can be very helpful to manage symptoms, as well as even using mood stabilizers like an antidepressant.
Are there some issues that increase a person's risk, a woman's risk for hot flashes? Like you mentioned obesity. No, you didn't mention obesity, but people can gain weight. But
that's one, though, yeah.
Having the excess weight. I mean, when we talk about breast cancer, androgen, when our estrogen starts to drop, am I right that androgen, or the male hormone, if there's more fatty tissue, it's converted to estrogen. So being overweight actually increases levels of estrogen that bumps the risk for breast cancer, uterine cancer. How does that play a role here?
Yeah, interestingly, it kind of shifts that it seems to be a protective factor against hot flashes and night sweats in the perimenopause time frame, but then post-menopause, it has more associated risk, and often women will notice a higher level of hot flashes. But there's some other risk factors too for hot flashes and night sweats. One, ethnicity. Black women like myself tend to have hot flashes for a longer duration. They tend to be more severe as well. And in addition to Native American women as well, there's some data showing that they also have more severe vasomotor symptoms for a longer duration. Lower education levels, as well as socioeconomic status, has been a risk factor for having more severe vasomotor symptoms as well. Tobacco use as well is also has been the study of women's health across the nation, SWAN, has been going on now almost 30 years. And it's the largest and the longest longitudinal study looking at aging in women. And the initial intake for Swan was in the late 1990s. There were 7 different sites across the United States where patients were recruited. Every city had a white cohort and then a racial ethnic group that was within the cohort as well. And they have assessed them annually, the people that are in the study. So there are over 3,300 people enrolled in this longitudinal trial that is still ongoing today.
We're so fortunate to have that data to look back and predict the future. Let's take a little break, and when we come back, more on menopause and symptoms.
Thanks for listening to Your Radio Doctor with Dr. Marianne Ritchie, exclusively presented by Independence Blue Cross. If you have a question for the medical mailbag, just send a note to doctor@yourradiodoctor.net.
Welcome back to Your Radio Doctor with our guest, Dr. Monica Christmas, the Associate Medical Director of the Menopause Society, an international organization that provides so much information and data to help women get through that transition called menopause. Monica, we were talking about hot flashes, and for anybody who's ever had them, again, they vary in intensity, but the typical presentation might be that sudden onset of a feeling of heat in the upper chest and face that can become generalized, last for a few minutes, can come with profuse perspiration, occasional palpitations, a feeling of anxiety. That can really influence a person's workday or their personal life. And we're talking about the risk factors. Carrying extra weight or obesity can be a risk factor. As you mentioned, ethnicity or racial, women of color are more likely to have hot flashes. Smoking, just another reason on that checklist and why we shouldn't smoke, because I guess the inflammation sets off the symptoms. But the other things we can control besides smoking, reduce physical activity. Another reason why exercise can be so beneficial. Yes?
Yeah, it's actually, there's good data that shows that it's weight loss, not necessarily exercise, but you need the exercise to get to the weight loss. So, but weight loss has been shown to improve vasomotor symptoms.
Mm-hmm. So other symptoms that are really important that you see. We know that our skin ages, but for women, I guess the estrogen helps to keep elasticity and moisture. So naturally, we're going to start to see wrinkles, which I think are badges of courage personally. But when there's atrophy and decreased blood flow to the pelvis, you're going to see more urinary tract infections, maybe, and decreased sex drive, obviously.
Menopause is inextricably tied to the aging process. And so there are a host of symptoms, litany of symptoms that one will, and you talked about skin, some people will talk about hair changes, weight gain, arthritic changes, or joint pain, so it can go on, but it's often difficult to disentangle what is truly due to estrogen deficiency versus what's due to our natural aging process. And we'll dial into all of them, but mood swings that could be irritability, increased anxiety, anhedonia, just that not having energy or the will to do the things that you normally did, can be, extremely disruptive, especially during the menopause transition. And it's likely due to hormonal or has been shown to be due to hormonal fluctuations, not the absence of hormone or the estrogen, but more to the lability. And it's very similar, that menopause transition is a vulnerable window, just like the postpartum period is. When you're pregnant, your hormone levels are sky high to sustain the pregnancy. As soon as you deliver that baby in the placenta, they drop pretty precipitously. And many people, not everyone, but many people are prone to postpartum depression. Even just monthly, there are many women during the monthly normal cycle where the levels fluctuate. You ovulate, they go up, and then they drop afterwards. And many people can be prone to PMS or PMDD, symptoms. Another vulnerable window is this perimenopause time frame. About 40% of people will experience mood swings. That's a lot of people. And if you have a history of having anxiety or depression in the past, even if you've been stable for many, many years, there's a higher associated risk of an exacerbation during the perimenopause transition. And so I think that's important to talk about, because many people feel dismissed with that, or they don't know what's going on. And although hormone therapy or hormonal birth control is not first line treatment for managing mood things, it can be helpful when it's these hormonal fluctuations that are affecting things. And then, of course, mood stabilizers like an antidepressant. In the postmenopause phase, though, if somebody's still experiencing pretty debilitating mood swings, it's more likely that that is actually true depression and probably isn't going to respond to just being on hormone therapy. And we should look at either psychotherapy or other ways to support patients, or treating them with first-line therapy for their mood symptoms. But I think that's a big symptom to touch on. The next thing I get, like the third, it's like vasomotor symptoms, and then it may be the mood swings. You mentioned the genital urinary symptoms, right? Those tend to be findings later on in the postmenopause phase. And we should mention, we didn't say this at all, but vasomotor symptoms will get better on their own. Now, they may linger for many years, but for the vast majority of people, they go away. There's about 10 to 15% of the population, I call them chronic flashers. My mom happens to be one that will have vasomotor symptoms for 20 or more years. So basically, they'll have them forever. But the vast majority of us, they do get better. Those genital urinary symptoms, though, are quite the opposite. They often don't get better without treatment, and some may even say they get worse over time. And you mentioned urinary symptoms. That's one: urinary frequency, urgency, recurrent urinary tract infections, but as well as vaginal dryness or itching, irritation that could lead to pain with any type of vaginal penetration or bleeding. Easy to treat, or I should say there are treatment options. Local vaginal estrogen therapy can be extremely helpful in helping those vaginal tissues become a little bit more pliable or stretchy, helping to bring more blood flow to the vaginal tissues, and even helping with the nerves feel a little bit more sensitized in the area. And local vaginal estrogen is really just absorbed in the vaginal. It's not systemically absorbed. So it's not going to help with hot flashes or night sweats, but people that have contraindications to systemic estrogen can still use local vaginal estrogen, and we shouldn't be withholding it from them. There are two non-estrogen options. There's a oral pill that's a SERM, a selective estrogen receptor modulator, that helps with the vaginal dryness that can lead to pain with vaginal penetration, as well as a steroid suppository that's really helpful as well. So there's a whole host of treatments that, again, nobody should suffer if they're experiencing those symptoms.
Sure. So a woman has breast cancer and has chemotherapy, has ovaries removed. Or let's say a woman who has her ovaries removed because she has a certain genetic syndrome, like the BRCA gene or the Lynch syndrome. Just for reference sake, not everybody knows what they are, but if a woman has a family history and she's advised to have her ovaries removed or breast cancer, is their menopause picture different than other women who transitioned more?
Well, you mentioned kind of two groups. I'm going to stay away from the breast cancer group. We can come back to them. But let's say the high-risk group, right? The people that either have a genetic mutation, or even those maybe their genetic testing is negative, but they're still at a higher risk when you do their screening because of their family history, or maybe they have dense breast tissue. So that high-risk group are not completely excluded from using systemic hormone therapy. And again, I'm not talking about the local vaginal hormone therapy. I'm talking about systemic dosing that would help with those pesky hot flashes and night sweats. And especially if those genetic carriers undergo risk-reducing surgery. So let's say they've done with childbearing, and at 43 or whatever age they decide to have their ovaries removed to reduce their risk. Those individuals, because we're putting them into early menopause, we actually really should treat them until they would have naturally gone through menopause, that early 50s range. So they should be on hormone therapy. The data doesn't show that their risk of breast cancer is increased by being on hormone therapy. And there's more, the benefits would be protecting the bone, so from bone loss, so that it increases their risk later for osteoporosis, as well as prevention of protecting against cardiovascular disease.
So I want to ask you, Monica, does their picture look different than somebody who gradually goes through menopause? Like if you, boom, your ovaries are gone overnight.
Oh, yeah, I misunderstood. Okay. I was asking you, I thought you were asking, should they be on hormone therapy? Yeah, when we abruptly put somebody into menopause, the symptoms often are more severe, more prevalent, more bothersome. It's a shock to the system. And so often, we don't want to just randomly remove people's ovaries. It's usually for a very good reason, but I'll start the hormone therapy right away. And some people, I hear some of my colleagues say, but aren't you worried about them recovering and being at a higher risk of a blood clot because they're recovering from surgery? Well, when we give hormone therapy, we're just getting them back to their physiologic level, right? So before the surgery, they were walking around with, a certain estrogen level. If we had left, and people that we just remove the uterus and we leave their ovaries behind, they're not necessarily at higher risk. So I think we still treat those people, and there's no reason to withhold treatment for weeks or months after surgery. I think that they should be started. I usually like to do a transdermal patch, really immediately after surgery.
So a woman is healthy, but prophylactically has her ovaries removed because of a genetic syndrome that's either there or family history. But a woman with breast cancer also, she has chemotherapy that might shut her ovaries down, and that's still an abrupt drop in estrogen. Does tamoxifen, which we know is maybe a supplement, we say adjuvant therapy, but does that bump the risk for hot flashes?
Yes, it does. And so we did, it's tricky though for that population. And it's really important to have these conversations beforehand because there's something about knowing what may happen to you, and even preparing and thinking about just healthy lifestyle strategies, maybe employing the help of a psychologist that is skilled in cognitive behavioral therapy, because CBT has been shown to not just minimize or improve vasomotor symptoms, but also help with anxiety and sleep disruption as well. And then also counseling them on all of the non-hormone therapy options that can help minimize symptomatology, and dietary and exercise influences too ahead of time.
So important. I think that warning really helps people. Stay with us during the break and hear about this week's Your Real Champion.
Now, Your Real Champion.
I know you've got the heart of a champion.
And now for Your Real Champion. I call this segment Ho Ho Hope. St. Nicholas was born in the 3rd century in Asia Minor, which was Greece at the time, but now considered Turkey. His wealthy parents raised him to be religious, but died while he was a young boy. He gave his entire inheritance to the needy, the sick, the suffering, and became a bishop as a young man. He was known throughout the land for generosity to those in need, his love for children, and his concern for sailors and ships. At the time, the Roman Empire persecuted Christians, and Nicholas spent years in prison. Upon his release, there were many legends about his good deeds, including the story of a poor man with 3 daughters. In those days, a young woman's father had to offer a dowry, something of value to a prospective husband. Without a dowry, a woman was unlikely to marry and often forced into slavery. Mysteriously, on 3 different occasions, a bag of gold appeared in their house. The bags of gold, tossed through an open window, landed in stockings or shoes left before the fire to dry. This led to the custom of children hanging stockings or putting out shoes eagerly awaiting gifts from St. Nicholas. Many stories like this explain why he's beloved as the patron of children, orphans, sailors, laborers, captives, victims of judicial mistakes, and the protector of all in trouble or need. He became the patron of Russia and Greece, and many European countries celebrate his feast day on December 6th, keeping the focus of Christmas Day on the birth of Jesus. We think of Santa as the jolly and benevolent father of Christmas. Children send their letters. He works all year with the elves making toys at the North Pole. And on Christmas Eve, he flies around the world with 8 reindeer, visits every house, and slides down the chimney to leave gifts. Of course, fueled by your milk and cookies. But what lessons do we learn from old St. Nick? Number 1, he makes a list and checks it twice, and does not give gifts if you're naughty, just nice. Well, that's important for children to hear. This is a meritocracy. A gift means more because you have to earn it. Number 2, we live at a time of techno-communication. If you're hungry, food's on your doorstep in an hour. You want a new dress? Delivered by tomorrow. It doesn't work that way with Santa. Whether it's a dolly or a new bike, children have to do their best in school, finish their chores, and count the days till Santa comes. They learn the concept of delayed gratification. Number 3, kids also learn that Santa knows best. You might want a motorcycle, but you get a great game board or a new book. You learn to be grateful for the gift you receive. And maybe the biggest plus to Santa's yearly visit is the hope he brings to children and adults alike. So many good messages, the joy of giving, the wonder of surprise, and a child's belief that he or she is special. A few weeks ago, I actually stopped and asked myself, why are we worried about the stuffing and the pumpkin pie? Why am I unpacking Christmas ornaments? Because when I look at the news, the world's an unhappy place. Add to that anxiety, loneliness, inflation. But then I realized traditions make children feel more secure. They make all of us feel more secure. And now more than ever, we need to preserve these traditions. Put our energy into customs that unite us, like pausing and coming together to give thanks. Teach your children the beautiful story of Hanukkah. Celebrate the birth of the Savior at Christmas time. Welcome all traditions, including Kwanzaa, Ramadan, Diwali. The message in all these holidays is love. You can show your love in many ways. It doesn't mean buying something. Maybe you can make a dinner for an elderly person. Maybe a phone call to someone who's sick or out of work. Or maybe you're the first to extend an olive branch or reconnect with someone after a difference of opinion. In the end, the message of love is up to you. You can be the light of Hanukkah. You can be the manger that offers a place for the newborn Savior to rest his tiny head. You can be the Santa bringing ho, ho, hope. We salute you, Santa Claus. You're a real champion. And welcome back to your Radio Doctor. We're learning so much about menopause, the patterns, the possible symptoms, who's at risk for more symptoms, and we'll talk about therapies. Monica, are there other risks that women should be concerned about after menopause? We talked about changes in the pelvic floor, increased urinary tract infections, changes in skin. What are some of the other big issues that really don't come to light right away?
As we get older, for men too, we start to lose muscle tone, and that muscle often is replaced by fatty tissue. Much of that fat deposits in the midsection. Can't think of a more horrible place for it to go. And mainly from an aesthetic perspective, we don't really want more weight in the midsection either, but from a health perspective, we don't want a lot of weight or fat around our vital organs like our heart. The incidence or the risk of cardiovascular disease go up as we age. As well as bone loss goes down. It starts to actually precipitously we lose bone starting in our mid 30s, and there are things that we can do about it. We don't just have to say, oh, this is what it is. I get asked a lot, should I go on hormone therapy? I don't have many symptoms. I had hot flashes, but they've been gone for a while. But should I be on hormone therapy to protect against cardiovascular risk or prevent osteoporosis? And whereas estrogen is good for the bones and can be used as prevention for osteoporosis, not treatment, but prevention. For cardiovascular risks, it isn't as definitive. And in fact, we all wanted it to be. That's what that whole Women's Health Initiative trial was about. We really wanted hormone therapy to minimize cardiovascular risk and really improve all-cause mortality. And that hasn't been shown. And so no one should be putting people on hormone therapy to decrease cardiovascular risk. And in fact, there may be some associated harms in older individuals over the age of 60 or more than 10 years from the onset of menopause. Now, the caveat to that is that in younger people that undergo premature menopause, those primary ovarian insufficiency people or just early surgical menopause, we do recommend that they be on hormone therapy to mitigate cardiovascular risk. The other one I get is cognitive. We get a lot of brain fog, right? And that's real. It's not imagined. And am I at risk for more cognitive decline or dementia in the future? That brain fog, though, although it is frustrating, I live with it myself now. Memory is impaired somewhat, that ability to recall names, but the good news is new learning is not impacted, and it does get better. It tends to be more noticeable or more pronounced during those perimenopause years. And we shouldn't be telling people that hormone therapy helps with that either. Hormone therapy is extremely effective for managing hot flashes and night sweats. So if we go back to your initial question, well, what can we do about it? That bone loss, cardiovascular risk, cognitive decline, I cannot stress enough how important it is for us to be extremely intentional about what we choose to fuel our bodies with and being meticulous with how we exercise not just our body but our minds. People that stay active physically and mentally do better. The Mediterranean diet, for example, has been shown to be associated with less osteoporosis, less cognitive decline, less cardiovascular disease, less incidence of diabetes. So there's lots of reasons to eat a plant-forward, healthy diet and have regular exercise. And I think if there was ever a magic jelly bean or the fountain of youth, that's what it is.
I was going to say, there is no magic pill. And and I think too, if you're Marianne Ritchie, who broke 10 bones after age 40, she's either very clumsy or there's something else cooking. So I saw an endocrine doc and I said, I'm made of potato chips. I sneeze and I break a bone. I'm really not that fragile, but 24-hour urine, you're supposed to spill 150 units of calcium. Mine was 342.
Wow.
So because I kept saying, I'm from a family of 4 sisters. Half of us have great bones. My mother and another sister and I are just like, we shatter. And there's a condition called hypercalciuria. I know you're familiar with that. So for our listeners, if you do have bone loss, as you say, men start to lose bone too. How do we separate what's related to the exact X on the spot, estrogen decreasing versus aging in general? But if you do have DEXA scans that aren't getting better despite therapy and all that, ask your doctor about that really inexpensive, non-invasive urine test, because you might have this hereditary condition where your kidneys say, calcium's stupid, let's just send it out. But with that cardiovascular risk, there are all kinds of explanations. It's more important that people realize that with aging and menopause, you might see a little bump in your bad cholesterol or your LDL. You might see a little decrease in your good cholesterol. So another reason to stay on top of those tests and go to your doctor once a year.
And take care of maintain blood pressure control.
Yes.
I see it all the time when people say, well, I don't want to start anything. I'm going to try to do it naturally. And I want you to do both. But cardiovascular disease is the silent killer of women. More women die from a cardiovascular related incident than all cancers put together.
Yes.
And we're much more scared of breast cancer when cardiovascular cardiovascular disease is more prevalent.
Right.
So I say, yeah, I do want you to do all of those healthy things, and I'll help you walk through it and come up with your regimen and give you information about healthy diets. But I still want you to go on something to lower that blood pressure, because hypertension is a risk factor for cognitive decline, right?
Yeah.
And
Yeah.
along the same vein, when you talked about, working up osteoporosis, in individuals. The other thing I get a lot is that people come in and they can tell me all about their terrible sleep, and they will blame it all on menopause. But many, many women that don't fit the same stereotype that men do when we think about obstructive sleep patterns like sleep apnea. Lots of women that are not overweight have sleep apnea, and that is what's contributing to their sleep. And yes, I want you to sleep better, because good sleep helps with overall quality of life too.
Sure.
But sleep apnea increases our risk for cardiovascular disease too, and other disease processes. And so yes, I want you to sleep better, but I also want to improve the sleep apnea or treat the sleep apnea, because that also has important implications for other health benefits as well.
Well said, because if your apnea means you stop breathing, for our listeners. So if you do a couple snores, then you go, your oxygen level drops, less oxygen to those little neurons in your brain, and you're picking them off. Just like, as you say, the cardiovascular. Dementia is not because you drank too much coffee or you didn't even have enough vitamin D in your diet or whatever magic chemical people want to point to. It's about blood flow and getting the blood to your brain, because blood brings oxygen. So as you say, it's layered, it's multifactorial, and we can repeat and repeat exercise, Mediterranean diet, but that's why. It's not just the estrogen. And as you say, there's no magic pill, but I know that one of the things you explain to your patients is that if you've had a hysterectomy, maybe you use just estrogen, but if you still have an intact uterus, too much estrogen is a stimulant for uterine cancer. So once your uterus is gone, you can be on just estrogen. But if somebody still has an intact uterus, you combine estrogen and progesterone. Am I right about that?
Yeah, so estrogen causes the lining of the uterus to thicken or proliferate. And if we're not shedding that lining like people do every month when they have a menstrual cycle, the collection of all that tissue within the uterus can increase the risk of endometrial or uterine cancer. And we certainly don't want to give somebody something that's worse than the symptoms that they came in with, right?
Right.
And so for people that still have a uterus, in addition to your estrogen, you need to either be on progesterone. That can be either as a pill, or one of my favorite things to do is just put a progestin IUD in. The progestin IUD helps to keep the lining of the uterus nice and thin, and it can stay in place for up to 8 years. Allowing for that protection. And then there's one pill that also is a combination of estrogen and a SERM. The SERM that's in it is basidoxifene, and that SERM has the same protective benefits to the endometrial lining. I like it a lot because there's less breakthrough bleeding with it. And if there's one good thing about menopause that most people collectively will say is, I'm not getting a menstrual cycle anymore. And oftentimes when you initiate hormone therapy in people that still have a uterus, there can be some breakthrough bleeding that can be rather disconcerting. And so when I can pick options that minimize any breakthrough bleeding, it's good for the patient and it's good for me too, because then I don't, get all the calls of, I'm bleeding, is this okay?
It reminds me of a sitcom episode I saw some years ago, and a young girl, she's probably about 12 or 13, says, Mom, I got my period, how long is it going to last? And the mother turned and said, till you're about 50. So there is no one size fits all. And there are lots of forms of estrogen that we've talked about. 2 quick questions. How do you decide what to prescribe? And secondly, we can take this into the next segment. We have to remind patients who are looking for a natural cure to please talk it over with you or their provider, because not all natural is safe and can interfere with your other medications, etc.
Correct. I usually what I do is I just break down. These are the non-hormone therapy options, and these are the hormone therapy options. And we've got lots of estrogen options, so it's always great if somebody doesn't have a uterus, because I've got like all kinds of things. But there's estrogen pills. The transdermal options are nice because with a pill, you swallow it, it gets metabolized in the liver, and it can bump up your body's clotting factors, which could give you a slight increased risk of like a blood clot. Most healthy individuals, that's not a significant concern, but it's there. The nice thing about the transdermal options, like a patch or a gel or a spray or a vaginal ring, is that they are transdermally absorbed through the skin and bypass that first pass liver metabolism, so you don't get that bump in clotting factors. And that's why most of us will go for a transdermal option. Now, there are combinations for people that still have their uterus. There are some combination pills where there's both estrogen and progesterone, or estrogen and the serum in one pill that you take daily. Or there's a patch that has both the estrogen and progesterone in it. And that's nice when you can give somebody one thing that they have to do. It's good from an economic perspective, but also from an ease of use. The only issue...
And remember to use it.
Yeah, you do. And one of the things I was finding is that when I would give them the estrogen separately with the progesterone pill, lots of times people started to realize it was the progesterone that maybe made them feel a little bloated, or gave them a little bit more breast tenderness, or made them feel a little bit more lethargic, and they would stop it. Oh, my daughter's going to get married. I don't want to have bloating in the dress, so they wouldn't take it for a week, and they realized that they felt better. And then all of a sudden you've stopped taking it, and now you're having some breakthrough bleeding because that lining of the uterus has thickened. So I try to make it foul-proof, so that you can't mess it up. So I put them together. The only issue with that is that there are not a lot of doses of combined therapies. And sometimes people want a lower dose, or we need to give them more estrogen. And that's when we have to separate them. That's kind of why I said I like that progestin IUD, because they can put the IUD in, forget that it's there, and then we can still have this wealth of estrogen options that people don't have to worry about.
Well said. Let's take a little break, and when we come back, we'll have our wrap-up about menopause. And welcome back to our final segment of Your Radio Doctor. We've learned so much about menopause from Dr. Monica Christmas from the University of Chicago. Monica, quickly want to say to our listeners that buying any drugs over the internet is not a good idea. Two things. You could go to a health food store. I'm sure people say, hey, what's the best natural treatment, or what's the best hormone or supplement I can take for menopause? And people talk about St. John's wort, red clover, black cohosh. Black cohosh, it's rare, but it can cause liver disease. So you need to be monitored, number one. And then you wanted to talk to us too about bioidenticals. That's a big thing. Tell us if you would.
Yeah. So I guess first, there are no herbal or supplements that have been shown to be better than placebo, meaning and there are not a lot of randomized control trials. So many of the trials that they have for certain supplements are small. They don't have a placebo group, but in the trials that do, if you give half the people the black cohosh, for example, and you give the other half of the people a sugar pill, everybody at about 30%, the same statistical significance. So placebo has benefit too. The same statistical benefit, they say that they feel better for a little bit, and then afterwards, a couple weeks later, nobody feels better. Any supplement that a patient is taking, especially if you're on other medications, you should share it with your healthcare professional just to make sure there's no contraindications.
Always.
Yeah. And you are correct. Black cohosh, especially at larger quantities, taken every day, could impair liver. And if you already have underlying liver or renal function, maybe it's something you should stay away from. In addition, many of these products will metabolize down to phytoestrogens. So if you've had breast cancer or at significant risk, you may not want to be on these as well. Ooh, and okay. Bioidenticals are huge. I will first say that bioidentical just means that the molecular structure of the hormone is similar to what your ovaries make. There are FDA-approved bioidenticals for people that want that. They confer the same risks that other hormone therapy carries as well. They're not any safer. But most people are referring to these hormones that are made from compounding pharmacies. And right now, pellet therapy or injectables are really popular. Pretty much every professional organization, including the FDA, has come out with warning statements against use. They do not have to undergo the same scrutiny that other drugs have to go through the FDA to show safety and efficacy. And so oftentimes these are maybe more harmful than helpful, but they also confer the same risk. And so if you have contraindications to hormone therapy, you still should not be on a compounding hormone. And they're usually not covered by insurance, so you're paying out of pocket. And if a provider is not sharing that information with you, that's really unethical as well, especially if your insurance isn't covering it and you're paying out of pocket for it. The Menopause Society has a great resource. For patients, it's free. You can get lots of information on the Menopause Society website for patients. There are videos as well that patients can access, but good evidence-based information. But there's a statement, about bioidenticals and gives you good factual information about those. And then there's also a statement about addressing misinformation and hormone therapy use that we just put out about a few weeks ago.
So 2 things. From what I understand, you said that these are pellets that are injected into the person's buttock?
Yeah, they can be pellets. They look like little grains of rice. There are also other injectables, and then there's creams, compounded creams that you can rub in your thighs too.
But I guess that makes the person feel like, oh, I only have to get it every 3 months, so I don't have to think about it. But again, are they being, well, I guess they're being monitored, but no spank me. I don't think I would make that choice, but you're helping people decipher. And people can get more information with the website for the Menopause Society. And what is that website, please?
If you just Google menopausesociety.org. Yep.
I'll take you right to it.
Yep.
It is a fantastic website with so much information. Well, Dr. Monica Christmas, I hope that your Christmas is wonderful. It's pretty chilly out there in Chicago in December.
It is. But this is my season, so I get pretty excited about it.
But I guess what people are wondering is, do you know Santa personally?
Of course. I am Santa.
I figured. So, and if you don't know, and if you do, I hope it gives you a discount. Merry Christmas, Monica. Thank you for sharing all that wonderful information. For our listeners, the Menopause Society has fantastic information, and we hope that this helped you make better decisions. Merry Christmas, Monica. Thank you.
Thank you.
Thanks for listening to your Radio Doctor, Dr. Marianne Ritchie, presented exclusively by Independence Blue Cross. To contact Dr. Marianne and to listen to today's show as well as past shows, visit yourradiodoctor.com.